Hello, guys, and welcome to part two of our pulmonary / respiratory. So where we last left off, we were discussing about differences between inspiration and expiration, right? So inspiration is where we bring things into our body. Expiration is where we bring things out. Sorry, I'm just skipping through. So we talked about the differences of pressure. And as far as ventilation versus respiration, ventilation means we're getting the air to places that it needs to be, or making sure there's adequate oxygen. So the important things to understand here is that when the volume in our lungs increase, it leads to that pressure change. Now I told you about how it's about pressure, pressure, pressure. So it's the increase in something called Starling's law. It's a very fancy law that basically says if you increase volume, you increase pressure. So it's a mechanical process for ventilation that depends on the volume changes in the thoracic cavity. So the more air that gets in, the more the pressure changes. Pressure changes leads to the flow of gases to equalize pressure. So that's the mechanical process of inspiration, expiration. Inspiration, we have an active process that uses our inspiratory muscles, and our inspiratory muscles are our external intercostal, which is our rib muscles, and our diaphragm, which the diaphragm is a piece of muscle, that big giant flap that hangs out underneath the lungs, that goes up and down depending on what we have to do. Okay, so during active inspiration, the diaphragm contracts and it moves inferior and flattens out, so it kind of comes down and flattens, and this causes the volume in the thorax to increase. Then we have the intercostal muscles. The intercostals will contract, which lifts the rib cage. So if you take a deep breath in, if anyone's yogis out there, you take a deep breath, you feel your rib cage expand, lift up and out. And what that also causes is an increase in the thoracic volume as well. Okay, so we're getting lots of things that are happening here to increase our thoracic volume. When we increase the thoracic volume, we're affecting the pressure. So for inspiration, when it comes to volume and inspiration, so inspiratory muscles are contracting, the diaphragm and lowers, rib cage rises. We increase thoracic cavity volume. The lungs are stretched, which causes the intrapulmonary, so this inside the lung, the volume increases. That pressure then drops. That increase in pressure causes a change in pressure. So a change of increase in volume causes a change in pressure. That change in pressure then allows for a pressure gradient to exist. So gradient means going from high to low. So an air gas flows into the lungs down its pressure gradient. So it's going against its pressure gradient until the inside of the pressure of the lungs is equal to that of the outside atmosphere, or what we're breathing in right now. So key things for inspiration, for active inspiration, is that we're using our diaphragm and our external intercostal muscles, and we're increasing the volume that's going to lung, and increasing that volume is going to cause a change in pressure. That change in pressure is going to what encourages those gas flows to exchange at the capillary level. Okay, and then for expiration, well, we need those muscles to relax. So the diaphragm comes back up because it doesn't need to increase that volume anymore. The rib cage then recoils, so it goes back to its original stance. So that decreases the entire volume inside the thorax. Lungs have an elastic ability to recoil, and that's passive, and that causes a decrease in the lung volume itself. And that causes the pressure to rise because we change the volume. And then what we have then is that the air gases flow out of the lungs down its pressure gradient until we have the inside of those lungs have a pressure of 0 again, and that's expiration. Okay, so expiration is normally quiet and it's normally passive. Okay, so inspiratory muscles, as I said, relax, thoracic cavity volume decreases, and lungs recoil. Okay, when we have forced expiration is when you're going and you're doing forcing it out. It's an active process, and we're using our oblique muscles and transverse muscles of our abdominal area, and we're using our internal intercostals. So the difference with expiration is that you're using and when it's forced, is that you're using your internal intercostal muscles as well as your obliques and transverse. And in inspiration, which is active, you're using the external intercostal muscles and the diaphragm. Okay, so this is just taking a look again of what we discussed before. Same slide. This is a great slide to take a look at to really understand. And remember, it's all about pressure, 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 volume changes pressure. So remember, inside an intrapulmonary pressure, the pressure inside the lung decreases as lung volume increases. So it's an inverse relationship. Intrapleural cavity, the pleural cavity also has a pressure, which becomes more negative as the chest wall expands during inspiration. And this allows our chest to return to its initial value as the chest wall recoils, which means that you can go back to start. And the volume of the breath is literally how much the pressure gradients can move, about 0.5 liters of air into and out of the lungs. So when we do special lung testing, we're actually testing to see how much volume gets into and out of our lungs. Okay, and then there's certain things that affect the ventilation of our lungs' ability to ventilate. So we have airway resistance. So how much resistance is allowing to stop or help the flow of air coming in. We have alveolar surface tension, which we know is done by surfactant, which is made by type 2 alveolar cells, which are cuboidal. And then we have lung compliance, which means the ability for it to expand and recoil. Okay, so lung compliance also means measuring the change of lung volume that occurs within a given change in the pressure. So how much stretch the lung has. So how much compliance depends on the recoil. So normally lung compliance is pretty high because the lungs have the ability to really distend, and we have surfactant that helps decrease the surface tension. And then higher lung compliance means it's easier to expand the lungs. So that you would think that would be a good thing, but sometimes that's not a good thing. And when compliance is diminished, it actually affects our ability to bring air in and out of our lungs. So a lot of times when there's fibrosis, so fibrous tissues replacing the lungs, that's going to disrupt the compliance or the abilities for the lung to stretch. If we don't have enough surfactant, we can't get that stretch. And if for some reason that thoracic cage, that cartilage is unable to expand and be flexible, that will affect the lung compliance as well. So if anyone's ever been to a pulmonologist or had any special pulmonary function tests, we're basically testing how well your lungs are working. And the way we measure that is for spirometry. And spirometry is a fancy little machine that you take a deep breath in, and you huff and puff and get all your volume out as quick as you can, as fast as you can, as much as you can out. And what it's doing is measuring quite a few things. And what we do, we're looking at the total lung capacity. We're looking at the forced amount that we have forced out of our lungs. We're looking at what's left over. I'm not going to make you guys responsible for knowing all the little nitty and gritties of pulmonary function tests, but what you do need to know is that when there's obstructive pulmonary disease, things like bronchitis, COPD is a fancy term for obstructive pulmonary disease. So we're thinking bronchitis, emphysema, asthma. Those are things that cause increased airway resistance, and we would see that in their lung function tests. When someone has a restrictive lung disease, such as tuberculosis or fibrosis, then their ability to expand their lung is compromised, and therefore we're going to see a decline in a lot of these numbers. Okay, as far as gas exchange goes, I'm not talking about farting here, but I'm talking about internal respiration. So external respiration, we're bringing the gas between the blood and the lungs. Internal, remember, is between the blood and the tissues. And both of these gas exchanges depend on what the gas makeup is in the alveoli, and also the basic properties chemistry-wise of gas. So inside the alveoli, they actually contain more CO2 and water vapor than atmospheric air. And that's kind of strange. You're like, why the heck is that happening? Well, it's happening because we need that oxygen to have a gradient and to have a pressure. So gas exchange in the lungs, the oxygen diffuses out of the lung and CO2 diffuses into the lungs. So if you think about that, if we're trying to get the oxygen out of the lung into the tissues, of course, there's going to be more CO2 in those alveoli because that's the whole idea of it. Also having more CO2, it's because there's a lot more humidity in the air from the conducting passageways, and therefore CO2 tends to get a little bit, not stuck, but the temperature-wise, temperature and humidification help keep it in there. And then when we take a new breath, like I'm trying to do right now, even though I'm talking a mile a minute for you guys. Okay, deep breath. So mixing the gas with each breath. So remember that each breath, you're going to get a mix of what's been left inside those alveoli and what's coming in. So there's always going to be a little bit more CO2 than oxygen, believe it or not, in those alveoli. As far as external respiration, remember, this is involving taking the oxygen and the carbon dioxide across the respiratory membranes, and you're doing from the lungs to the blood. How does that, remember, it's all about the pressure. If I'm talking about lung, I'm talking about volume and pressure mostly. So the exchange at the external respiration depends on the partial pressure gradients, which means the differences between intrapulmonary, on one side of the alveoli over this other alveoli, and the solubility that the gas has in that current situation. Also, thickness and the surface area of a respiratory membrane can definitely influence how we can get oxygen in and out. If you think of thicker membrane, will be less. And if you have more surface area, the more ability you have to get external respiration. Then we have something called ventilation perfusion coupling, which is a fancy terminology, which means that how much the alveoli are actually bringing air in and how quickly that pulmonary blood is perfused with oxygen, which means that we're infusing it with oxygen. So taking a look right here, so inspired air, we look at the partial pressures of things, not the whole pressure, because air, it's altogether has a pressure, and then each component, oxygen and carbon dioxide, they add up to the total pressure. So we have to take the partial pressure of each gas to take an idea. So inspired air, when we take it from the outside, we're getting about 160 millimeters of mercury of oxygen, 0.3 millimeters of mercury of CO2. And then, so that's what we have when we inspired it. Now keep in mind that we take it in, we're working in the alveoli, we're doing some external respiration. So the capillaries are doing some gas exchange, and inside the alveoli itself, it has as you notice that the CO2, the partial pressure of CO2 is actually at 40 millimeters of mercury, and the partial pressure of oxygen is a little bit lower. And that's because we always have more CO2 in our alveoli than we do in the outside world. Okay, so if you see here, when we're going with internal respiration, at least from the cardiovascular aspect, when the tissue is entering and leaving the lungs, those oxygens and CO2 end up equaling out. And then when we're going into the actual systemic capillaries, you notice that the partial pressure oxygen is rising, and it's still a little bit about the same, but rising more than you would see from the tissues going leaving tissues and entering the lungs. We need that because remember the pressure, it's all about the pressure. So ventilation perfusion coupling is basically a fancy thing, which remember perfusion is the actual blood flow reaching the alveoli. Ventilation is how much gas is reaching the alveoli. A lot of times we'll look at this in medicine, and if it's called a perfusion ventilation mismatch. If it's mismatched, we need to figure out what's causing the mismatch and treat that aspect. So we have many things that control our external respirations, but the foremost and most important ones is that we have these autoregulatory, these homeostatic controls. A lot of people I noticed on the pop quiz got hemostasis confused with homeostasis. Hemostasis is the coagulation of blood. Homeostasis is bringing things to an equilibrium or balance. So the partial pressure of oxygen controls perfusion, which means if we need more oxygen or we need more perfusion, we change that arterial diameter by either doing sympathetic nervous system constricting it or vasodilating it. And then partial pressure of carbon dioxide also controls ventilation. So when we think of oxygen, we think of perfusion. We think of ventilation, we think of carbon dioxide. And if we have to change the partial pressure of our carbon dioxide, we do that by changing the bronchiolar diameter. So remember, partial for perfusion, it's all about oxygen and blood vessels. So we're thinking more arterioles. And then for carbon dioxide, that's more ventilation concern. We're thinking more of bronchioles. Okay, and interrespiration involves capillary gas exchange in the body. So we kind of really got home about point. Remember, it's all about these partial pressures here. So it's about the change. I'm not going to make you guys responsible for exactly knowing the physics of it, but understand that there's a change in partial pressures that causes a uptick or downtick of where the oxygen or carbon dioxide is going to go. Okay. And speaking of, so now we're in the blood. We talked about how we get that oxygen from the lungs into the blood, which is by partial pressure gradients, and how we get to the tissue with perfusion versus ventilation. Now we're going to talk about the oxygen itself and what we're exactly looking at when we transport gases in the blood. So molecular oxygen is the kind that you see on the periodic table of elements. We carry it either as dissolved in the plasma, but most of it is bound to our hemoglobin, which remember, hemoglobin has an iron ring and it can hold on to 4 oxygen, okay? which we may have not gone over in blood, but now we are. So each hemoglobin has the capacity to hold on to 4 oxygen, but oxygen can be bounced off, flicked off easily, and can be put back on.
Hi, sorry. Yeah.
So when we're talking about oxygen, when we're talking about oxygen, we're also talking about the hemoglobin concentration, but oxygen, when it's bound to hemoglobin, has something called, sorry, there was someone in my office and I wasn't sure what was going on. They have ability to load and unload oxygen. So oxygen gets on the bus known as hemoglobin. And when we need to get off the bus, it goes to the bus stop and drops it off. So when oxygen binds to hemoglobin, it actually changes its shape. So when we have one person on the bus, one oxygen, it has a greater affinity for oxygen. So one oxygen means that more likely to get all 4 of them saturated. But when oxygen is released from the hemoglobin will change its shape. And when it loses one oxygen, has a more likely for it to shed more oxygen because it's thinking this person must need oxygen, so I should let go of it, or this person must need oxygen, I must hold on to it and bring it somewhere. So it's kind of hanging out in a group. So when we're looking at what's called oxygen saturation, you might have heard a lot about that going at COVID. It's seeing how many oxygens each heme group is carrying. Fully saturated is 100%. We actually don't want you at 100% all times. The typical oxygen saturation percent for a healthy individual is anything above a 95 to 100, and even dependent, so, and it changes on age. And under COPD, so chronic obstruction, so things like emphysema, it can also change those amounts as well. Partially saturated hemoglobin means, or partial oxygen saturation means that it only carries 1 to 3 oxygens and then instead of the full boatload. So a lot of times when we look at oxygen saturation, we're looking at what's called the oxygen association and hemoglobin association curve. And this is an S-shaped curve. And what it's looking at the rate of loading and unloading of oxygen. And what it does is it's tightly regulated to ensure that oxygen can get to the cells. So there's a few factors that influence how well saturated hemoglobin is. And that, of course, is pressure. The partial pressure of oxygen is going to influence it. But temperature, the blood pH, partial pressure of carbon dioxide, and also concentration of that's called VPG will influence how much the hemoglobin has an affinity to hold on to that oxygen. So when we're looking right here, we're seeing that ideally, or like right here, if we're looking at the tissues, when it's once delivering, it's normally getting to about 80%, 75 to 80% oxygen. But when we are looking at our blood, we are looking for that goal of 96%, which means all 4 oxygen are on the bus, okay? And so as I said, the partial pressure of oxygen is very influenced by the release of oxygen from the hemoglobin. And that's what we're charting. It's an S-shaped curve, and it's called the oxygen hemoglobin dissociation curve. Sorry, I might have called it a little bit differently before. So an example here is this person is training at the beach versus a high altitude. So high altitude can adjust how much our oxygen has an ability to hold on to the hemoglobin. At sea level, this guy's doing well at 98% oxygen saturation, but the higher we go up, the less, because the oxygen is less pressure up there, that partial pressure then affects the partial pressure of the oxygen in the lungs. And therefore, even though hemoglobin, there's no real change in the amount of oxygen we're taking in, the ability to saturate that hemoglobin gets affected. So therefore, you have a little bit lower of an oxygen saturation. Same thing with being at rest and being exercised at rest. You don't really need to use all your oxygen because you do need your oxygen, but you're not, your other tissues in your body are not requesting it or requiring it. Sorry, my phone is ringing. Just have to make sure it's okay. Hold on, I have to pause this for a moment. Sorry about that. Primary care is always fun. I am back. So going back to what we were discussing here, is that person at rest, I mean, they don't really need their oxygen to go places. So at rest, they're going to have about, typically about 75% of the oxygen is actually being fully saturated, where only some of it needs to be released. But if someone's exercising, they're going to need that oxygen to be available really quick. So yes, your oxygen saturations won't, as far as up here when you do it on the on your finger to test it, won't be off, but we need the ability to be releasing those oxygens. And during exercise, what ends up happening is that after one oxygen is released, it's actually causing a change in hemoglobin, and it has an affinity to release more oxygen to the skeletal muscles that need it, because it only has about a 40% capacity there, if that makes sense. So, as I said, increases in temperature, changes in pH and BPG. It's a fetal aspect that can be that can alter your oxygen transport curve. Typically, when we have increase in in partial pressure of CO2, BPG, and hydrogen ions, also known as increase in decrease in pH, it results in a decrease for the hemoglobin's affinity for oxygen, and we'll see this a lot of time in the systemic capillaries. And basically, what happens is that you hear what's called a shift, a curve to the right. And a curve to right means that the oxygen has been starting to unload. So that curve actually shifts over to the right. You'll see that in the next picture. And then when we decrease these factors, that affect it, it gets a shift back to the left, which decreases oxygen loading from the blood, and therefore the hemoglobin stays more saturated. So you can see here, normal body temperature is 38 degrees Celsius, 98.6. But when we have a fever, it's going to actually, what it's going to do is going to shift to right, and it's going to cause that oxygen to be more likely to disassociate from the hemoglobin, because your body needs that oxygen to boost free to do all sorts of things like peroxisomes, helping out with increased heart rate, increased respiratory rates, those type of things. And then we're looking here what happens when we have the partial pressure of carbon dioxide. When we have the decrease in the carbon dioxide, the pressure decreases, or we have a raise in pH, we get a shift to the left. So the oxygen dissociation curve tends to allow more holding on to oxygen, but then the opposite occurs when we increase the carbon dioxide or decrease the pH. So a fun thing is that a lot of times when someone's having a breathing issue, like if they have COPD, remember we naturally have a little bit more carbon dioxide in our body as it is in the alveoli. If someone has COPD and can't get the expired air out, they're always going to have more carbon dioxide at present and less partial pressure of oxygen. So that's going to really affect the ability. If we gave someone pure oxygen, but there's only increased carbon dioxide, that can actually do a negative effect. And I'll explain that more later. So for carbon dioxide, remember that we not just only have to transport oxygen, we need to transport carbon dioxide, which is our waste. So about 10% of it is dissolved in plasma, and that's what gives us the partial pressure of carbon dioxide. Some of it is bound to hemoglobin, and these are bound to the globin part, not the heme part, not the iron-containing part of hemoglobin. And then this is referred as carbaminohemoglobin. So what we're seeing here is, when fancy terminology, when you add CO2 to hemoglobin, you get carbanohemoglobin. That is chemistry. Okay, how do we transport it? Most of carbon dioxide is actually in the form of bicarbonate ions. And what that does is it forms a weak acid, weak base, so we can easily dissociate. So it's not just that we have carbon dioxide and that's all you can do with it. We need to be able to buffer and to work around the system. So when we add carbon dioxide with water, we get this thing intermediate called carbon dioxide. Carbon dioxide is not carbon dioxide. Carbonic acid is a very weak acid, and when we dissociate it, we get that hydrogen ion and a bicarbonate ion. This is carbon dioxide transport is mainly happening in the red blood cells, and we need an enzyme for this reaction that we talked about earlier right here. It's an enzyme called carbonic anhydrase, and this helps make the reaction really fast. It also makes it reversible. So if we have too many bicarbonates, guess what? This formula can go in the opposite direction. If we have too many bicarbonates present, then we get more carbonic acid, and then that in turn gets changed over kind of with the anhydrase to make CO2 and water, and we expire it out, or vice versa. Our hydrogen ions or carbon are too low, so we go the opposite direction. We take more carbon dioxide and water, okay? So this is just a fancy way to show transport inside the red blood cells. So here outside the red blood cell, we don't have that anhydrase. So carbon dioxide, we can have it just diffuse really slowly into the plasma. We also have very slow form where if it's happening on the plasma, we have the CO2 that can become a bicarbonate through this process, but it's very slow and it binds to plasma proteins. But then we need this really fast thing going on, and that's where the CO2 can react really quickly, because in the actual red blood cell, we have the carbonic anhydrase, and that's the enzyme that catalyzes the CO2 plus the water to form this weak acid that can easily dissociate into a bicarbonate and a hydrogen ion. And here we just have to know that chloride is a player. I'm not making her not a player like, hey, baby, player, but a player that can work. And then what ends up happening is that we have hydrogen ion bound with hemoglobin. We have that carboglobin going on. Okay, so capillary, in the pulmonary capillaries, remember that this process occurs in reverse. So that's what's happening in the body out there. And the pulmonary, so the previous thing was what's happening in the actual tissue. In the pulmonary capillaries, we have the bicarbonate, which moves into the red blood cell, while the chloride moves out of the red blood cell back to the plasma. That bicarbonate binds with the hydrogen to form that weak acid. That weak acid is then split by carbonic anhydrase to make CO2 and water, and we diffuse CO2 into our alveoli and hopefully to expire it out. So that's everything in a nutshell right there. So remember that CO2, it's a carbonic acid bicarbonate buffer system. It's a way for us to be able to increase or decrease our pH when we need it. And remember that normal pH, we want it between 7.35 and 7.55 ideally. Anything above 7.55 is too basic, and anything below that is too acidic. So with this buffer system, if the hydrogen iron ions concentration increases, remember that makes it more acidic. What our body does is it helps remove the excess hydrogen ions by combining the bicarbonate with the hydrogen ion to make that path over, so we can just breathe that as water and CO2. But if our hydrogen ions concentration is decreased and becomes more basic, then we're going to release some hydrogen ions to bring that acidity back up. So remember that the bicarbonate is an alkaline reserve, a carbonic acid bicarbonate buffer system. So it really is there to help us maintain that pH. So when we change that rate of respiration, and depth of respiration affects our blood pH. So if we do shallow, slow breathing, what we're going to do is, really shallow and slow, what we're going to do is we're actually going to increase the amount of CO2 in the blood, and we're going to see a drop in pH, because that CO2, there's more CO2 present to react with the water. The water then makes a weak acid makes more hydrogen ions. But when we're hyperventilating, what we're actually doing, so we're hyperventilating, doing rapid deep breathing, kind of like that, we are causing a decrease in the carbon dioxide, which will rise the pH. So if we're hyperventilating, remember that's going to rise the pH. And then when we change the ventilation, so we change the rate of how we're breathing and how the air is exchanged, we also can change the pH and metabolic factors. So our breathing rate plays a major role in how we maintain our acid-base balance. Not only do our lungs play a role with the breathing rate, but our kidneys, when we come to that in another week or two, I think actually next week, we get more into about what the nitty-gritty of that is. As far as how do we control our respiratory rate, the pons medulla is really our main areas are. We have we have a center called the pontine respiratory center, and that's in the medulla. And then we also have different groups. I'm not going to have a response for knowing the groups. All I want you to know is pons medulla are responsible for maintaining that respiratory rate. And a good way to remember, if you had to remember the phrenic nerve, which nerves from the spinal cord innervate that. So the saying is C3, 4, 5 keeps the breathing alive. That way we know the phrenic nerve gets innervation from C3, C4, and C5. Sorry about that. Busy primary care practice, right? Trying to do this in between patients for you guys. Okay, so factors that influence breathing rate and depth. We know about the higher brain centers. We know there's certain chemicals that can affect how our breathing rate and depth are. There are certain things that really irritate the pulmonary reflexes, and there's inflation reflex. So if we remember that partial pressure of CO2, is really responsible for ventilation, that we have to understand there's actually a negative feedback loop for homeostasis. And what that is there's a sensor that senses the partial pressure. It's called a baroreceptor. It senses the partial pressure. It's normally by your carotid of carbon dioxide in the arteries. And if it's low, what it does is that it could essentially chemoreceptors in the carotid, not baroreceptors. The chemoreceptors in the carotid send signals to the brain. The brain then sends signals to the other aspects, which is the respiratory muscles, to either increase or decrease, which increases more ventilation, so more CO2 is exhaled out. Then your partial pressure in your arteries of CO2 is normal, and then that pH can return to normal. And yes, hashtag exercise is really good for you guys. I swear, it's super fun. I'm going to go for a hike after work today. So during exercise, we need to adjust things to make the intensity and duration so our body doesn't either not get enough oxygen or hyperventilate. Now we're called something called hypernia, which means that you're increasing your ventilation, so ability to get air in, to meet the needs of your body. So when we exercise, our ventilation increases about 10 to 20 fold. Okay, and that kind of makes sense, right? If we work out, we need more oxygen. More oxygen means we need to get more ventilation. And then with exercise, the increase in ventilation, there's 3 different factors that get involved here. So when we think about exercise, our body's already prepping ourselves. It's called like going right before a race and you're like, oh, I got to get ready. There's psychological stimuli. So the anticipation exercise might cause some epinephrine, norepinephrine release. We have the cortical motor activity of the skeletal muscles and respiratory centers that get fired off. And then from the respiratory centers, from the brain, we have reception from our bodies to start moving our muscles or joints and our tendons. So with all these, the gradual increase and plateau of this respiration then causes an increased rate of CO2 delivery to the lungs. So more basically exercise is good, guys. That's what my point being. And as I said, with high altitude, it actually results in a lower than normal hemoglobin saturation level. Remember back in the blood, I said that sometimes athletes like to train at higher altitudes because it makes it that you don't need as much oxygen to have as much stamina. But that with doing that, well, not even that, with not having as much oxygen, your EPO is stimulated, and that EPO then increases the number of red blood cells. So in short term wise, it can increases your stamina if you can work out at that higher altitude. But in long term wise, this EPO is going to make an increased number of red blood cells. And remember, red blood cells hold on to oxygen. Oxygen is what gives us energy as far as cellular respiration. Okay, and then we're going to talk about COPD here, which is some serious stuff. Don't smoke cigarettes, don't smoke pot, don't do any of those things. And if you live in a large city, you're probably getting air pollution. And these can do 2 different things. These can either irritate that lining of the bronchi and cause inflammation, or they can actually break down the elastic ability of your tissue to be able to expand. With chronic bronchitis, which happens in heavy smokers, both these happen in heavy smokers, but chronic bronchitis, you get a lot of mucus production and a chronic, what's called a smoker's cough. And what this does, remember that mucus is supposed to be there to help trap things and take it away. But if you're constantly making a bunch of mucus, you're going to trap stuff. You're going to even trap air. A lot of times you have dyspnea, and dyspnea is basically some difficulty breathing with movement, and then you get frequent infections. With emphysema, not only is it due to smoking, but some people have a deficiency called alpha-1 antitrypsin deficiency, which is an issue with the liver as well. And what this does is the elastic tissue in the lungs get broken down. So the alveolar walls get broken down. You don't have the ability, the elasticity for the lung to stretch. And same thing happens. Things get trapped, can't breathe. We're having loss of oxygen, loss of ventilation. And then eventually, if we keep having the CO2 rise, remember that's going to cause our blood to become more acidic because it's going to push over that equation to be more towards the H plus and bicarbonate aspect. And with asthma, there's 2 different types, but in the acute asthma, remember this is moderated by IgE, which is a allergy aspect. But COPD is with asthma is chronic asthma, so chronically happening. And you'll see coughing, difficulty breathing, wheezing, and chest tightness. And what's happening is that the airways are getting thickened because the IgE is triggering a response for those bronchospasms to occur, and this makes more and more bronchospasms, makes the airway thickened, and therefore unable to get air in or out very well. With TB, I'm sure you all had to get a TB test before going into school. Not sure about right now, but before, TB is a type of mycobacterium, and it's very difficult to kill and difficult to stain. Typically, someone will be having a fever, night sweats, weight loss, this really bad racking cough that you can't get rid of, coughing up blood. A lot of times healthcare workers are always screened for this. So you guys will be healthcare workers in 2 years. And typically we treat this with antibiotics that are very specialized. And then there's sleep apnea, which you'll run into a lot as a dental hygienist. Sleep apnea is either due to obesity, due to abnormalities in the airway, or sometimes people have really big tonsils that block the way. Typically, these people might be snoring, but sometimes they're not. And what's happening is that they're having a temporary stopping of their breathing while sleeping. What we do is we end up doing a nighttime test, and we measure the amount of times that they don't have breathings in a certain time period. And if their apneic episodes exceed a certain amount of time, then we classify that as sleep apnea and we treat them with a CPAP or some other method. People are not usually aware of this, but what's the number one things that I see in practice that people have high blood pressure and they can't explain why. There's lots of depression because they're not getting a ton of oxygen, so their brains aren't fully functioning. Lots of daytime sleepiness is occurring because their body, they don't even realize it, but they're waking up several times a night if they don't have any oxygen, and it could be up to 30 per hour. And then obstructive is the most common type that we see, and that is where the upper airway is basically causing obstruction. And a lot of times the pharynx muscles relax during sleep, and a sag in those muscles can cause obstruction there as well. That's all I got to say about that. That's it for respiratory. I know that the acid base can be a little bit confusing, but just understand that buffer system is there to allow for an adjustment, fast adjustment in the red blood cells. And it's all about the bicarbonate and the hydrogen ions that debate whether we're going more basic or more acidic. When we get to kidney, there'll be a lot of talk about acid-base balances there. If you guys have any questions at all, please feel free to ask away. All right, thank you guys. I am sorry, that's a lot to go through. Have a good one. Bye-bye.